Using the olive oil in this case for a different reason. In the first case, I was using it to homogenize the wax. It was really mushy and loose. I'm trying to bind it together. Here, I'm just trying to soften it to get a suction grip, because it was, although it wasn't dry and hard, it was really impacted. And if you soften the surface, as you can see, I can break through it, which then makes the wax a bit easier to remove. I'm also using the oil to lubricate the canal wall edge where the wax is impacted against, which will help me peel it off. So there's two different purposes between patient 1 and 2 as to how the olive oil can help. So I'm just bringing this down. So this isn't soft and mushy like patient 1, it's a bit firmer, and the oil just helps to just lubricate around the edge, the perimeter, the circumference. And in the core, you can see I've broken it up a little bit because I have managed to soften it. So we're just leveraging this away. As we are, we're just going away from the ear canal wall so we can separate and detach the wax and the skin that's enveloped this wax plug away from the canal wall. And at all times, as I'm maneuvering the suction probe, I'm trying to maneuver away from the eardrum. If you poke too hard and embed too hard with the suction probe against the wax plug, you're just going to push it towards the eardrum, which can be uncomfortable. So you can see the eardrum in the distance. We've just got this really adhered wax and keratin at the base. I'm just hovering over. We're going to be careful. I've decided, I think, to try to remove it from near the entrance, the cartilaginous portion. So here we have got a bit of a margin of error, so to speak, because the cartilaginous portion is a lot less tender and less sensitive than the bony part. So if I peel it from the cartilaginous region towards the bony part and away from the canal wall, it just makes the procedure a bit safer as opposed to trying to remove it the other way. Sometimes you've got no choice. You've got to start from the bony part of the ear canal and then come back to the cartilaginous portion. But here I was able to work towards the bony part, and as we're approaching the bony section of the ear canal, I can just lift the suction probe away from the wall itself. Now, just going to be careful here because we're in close contact with the canal wall, the bony part. And we're just going to hover over this. I think if it comes away, brilliant. If not, then we're not too concerned. I've just attached the fine end suction probe, which gives me a bit more precision in my hand movements. Okay, we're literally just kissing the surface, and as we are, we're coming away. And I think that's about as much I'm going to try and remove. It's not significant, that wax, it's just a bit smearing. And last but not least, this is patient 3. Now, this patient had already used drops prior to attending, and it's really softened the earwax. It's right up against the eardrum. You can see all that, the drops. I'm not sure if they used olive oil, but it may have been hydrogen peroxide or sodium bicarbonate, but this is smeared right up against the eardrum, so no doubt the patient's also been, in an attempt to remove it, pushing it. You can see the outside there is really sore and dry and tender, so they have been getting some itchiness. They have got some scar tissue in the southern hemisphere. You can see all that white calcification of the eardrum. That can occur secondary to physical trauma, barotrauma, so pressure change either by air or water, infection, surgery, even acoustic trauma over the years, but that's less likely. You can have surgical trauma, so grommets, for example. Grommets are normally inserted on the